Let's jump straight into this high-yield, symptom-based clinical decision tree for postpartum complications. No introductory filler today. We're getting right to the core clinical logic, mechanisms, and presentations you absolutely need to master for your Step 2 CK exams.
Think of our agenda as your cognitive map for this explainer. We're organizing the differential diagnosis chronologically by timing after delivery. So we'll start with symptom timing, then hit postpartum pituitary infarction, obstetric trauma and fistulas, pubic symphysis diastasis, and wrap up with postpartum urinary retention. Let's go.
Section 1. Timing after delivery. This is your primary organizing principle for distinguishing between all these conditions on test day.
If you don't catch the days postpartum in the very first sentence of a clinical vignette, you're already behind, right? When a patient presents, your first question has to be, is this immediate or is it days to weeks later? Immediate bleeding strongly points to uterine atony, retained placenta, uterine inversion, genital tract trauma, or coagulopathy. But if they show up days or even weeks later, you've got to shift your thinking entirely. We categorize these delayed complications by their chief complaint. Are we looking at lactation failure, pelvic pain with trouble walking, or maybe urinary or fecal leakage? Nailing down the specific symptom drives you straight to the diagnosis. Oh, and we have to add one more critical, delayed symptom to this mental map: fever. If she has a fever more than 24 hours postpartum with uterine fundal tenderness and purulent lochia, you should be thinking postpartum endometritis. It's polymicrobial, strongly linked to C-sections and prolonged rupture of membranes, and treated immediately with clindamycin and gentamicin. But if you see persistent fever despite those broad-spectrum antibiotics, with no localizing signs and a totally negative infectious workup, shift your logic to septic pelvic thrombophlebitis, which is an infected thrombosis of the pelvic veins. You treat that by adding anticoagulation to the antibiotics. All right, Section 2. Let's move to our first major delayed category, focusing on systemic issues driven by severe obstetric hemorrhage: postpartum pituitary infarction.
Let's break down Sheehan syndrome. The mechanism here is a direct consequence of severe obstetric hemorrhage complicated by profound hypotension. See, during pregnancy, the pituitary gland gets huge. It becomes supervascularized and demands a massive blood supply. So when that massive hemorrhage happens, the acute systemic hypotension causes ischemic necrosis of that highly demanding tissue. It's literally a postpartum pituitary infarction.
This results in the cascading hormonal failures of panhypopituitarism that happen right after that infarction. It's not just one hormone dropping out. The whole anterior pituitary axis shuts down. You've got a drop in FSH and LH, leading to amenorrhea, hot flashes, and vaginal atrophy. You see low TSH causing central hypothyroidism, think fatigue, bradycardia, cold intolerance. Low ACTH leads to anorexia, weight loss, hypotension, and even hypoglycemia. Plus, low growth hormone decreases lean body mass. But out of all these systemic failures, what is the absolute earliest clinical sign you're going to see?
The absolute earliest clue is lactation failure. Prolactin levels plummet immediately, so the mother simply won't be able to produce milk. If you see a failure to lactate after a massive postpartum hemorrhage, Sheehan syndrome needs to be at the very top of your list. Now, management is straightforward, but it's critical. Replace the deficient hormones individually. And here's a huge exam day trap, so listen up. Always replace glucocorticoids before thyroid hormone if you suspect adrenal insufficiency. If you do it backwards, you'll throw the patient into a life-threatening adrenal crisis.
Moving right along down our timeline to Section 3, obstetric trauma and fistulas. Let's look at physical injuries sustained during delivery.
We absolutely have to break down perineal lacerations by depth because that depth dictates the risk of future complications. A first-degree laceration? That's just the vaginal mucosa or perineal skin. Second degree goes deeper into the perineal muscles. But the crucial takeaway here is distinguishing the third and fourth degrees. A third-degree laceration hits the anal sphincter, and a fourth degree tears all the way through the rectal mucosa. These severe injuries drastically increase the risk of fecal incontinence, local infection, and delayed wound breakdown. You'll often see a vignette where a patient comes in a week later with increasing perineal pain, and the suture line is actually separating, even before a fistula forms.
Let's apply this with a classic board-style vignette. What's the likely diagnosis in a patient presenting with foul-smelling brown discharge from the posterior vaginal wall 2 weeks after a vaginal delivery complicated by a third-degree laceration? Pay close attention to the timing, 2 weeks out. And the location. This is not just your normal lochia rubra. The foul smell and that posterior wall location are your massive clues.
You guessed it, the diagnosis is rectovaginal fistula. Obstetric trauma is a massive risk factor here, right alongside previous pelvic surgery, pelvic radiation, colon cancer, diverticulitis, and Crohn's disease. Basically, the physical trauma creates this unnatural tract connecting the rectum directly to the vagina.
And the clinical presentation is highly specific. The patient will literally report the uncontrollable passage of flatus or feces through the vagina or that foul-smelling brown discharge we just mentioned. On physical exam, your key buzzwords are a patch of red, velvety rectal mucosa clearly visible on the posterior vaginal wall. The diagnosis might be super obvious on a basic pelvic exam, but things like fistulography, MRI, or endosonography are used to map out the exact architecture of that tract before they go in for surgical repair.
Now, we've got to contrast that with vesicovaginal fistulas. The risk factors share some overlap, like pelvic surgery and radiation. But here, prolonged labor, childhood trauma, and genital urinary malignancy are the major triggers. The tissue between the bladder and the vagina undergoes this prolonged compression, which leads to necrosis and eventually a tract. Picture a test vignette of a patient in a resource-limited setting with a multi-day obstructed labor. Now she's presenting with painless, continuous urine leakage from the vagina.
Drawing a hard diagnostic boundary between these two is absolutely essential. With a rectovaginal fistula, it involves the posterior vaginal wall and presents with gas or fecal leakage. Contrast that with a vesicovaginal fistula, which involves the anterior vaginal wall, and the patient experiences continuous painless urine leakage, frequently with vaginal pooling of clear fluid or visible raised granulation tissue right there on the anterior wall.
So how do we confirm it? The preferred diagnostic test for a vesicovaginal fistula is the bladder dye test. You instill a blue dye directly into the bladder using a catheter, and then place a standard tampon into the vagina. If that dye leaks through the anterior vaginal wall and stains the tampon blue, boom, you have definitive visual confirmation of the fistula tract. Cystourethropy can also be used to evaluate the exact size and location of the defect.
Section 4. Pubic symphysis diastasis. Let's shift our focus entirely to a complication that frequently mimics a severe neurological injury, but is in reality strictly musculoskeletal.
This condition is fundamentally an issue of extreme mechanical stress. Risk factors like fetal macrosomia, multiparity, precipitous labor, and operative vaginal delivery put massive outward pressure on the pubic symphysis, causing the joint to abnormally separate.
The presentation is really striking. These patients have severe difficulty ambulating. They'll have radiating suprapubic pain and acute tenderness directly over the pubic symphysis. They might feel like their legs just can't support them at all. But here's the absolute key differentiator on the physical exam. They present with a completely intact neurological examination. No motor or sensory deficits. Reflexes are totally normal. This intact neuroexam is exactly what differentiates it from a postpartum femoral or obturator nerve palsy, which would actually present with motor weakness or absent reflexes. Because it's a musculoskeletal issue, the treatment is entirely conservative. We manage it with NSAIDs for pain, physical therapy, pelvic support garments, and activity modification. It almost always resolves within the first 4 weeks postpartum.
And finally, Section 5, Postpartum Urinary Retention. Let's look at immediate urologic dysfunction. It is absolutely vital to differentiate the symptom timing here. Both fistulas and urinary retention involve the urinary tract, sure, but the timing is completely opposite. Think about it. Vesicovaginal fistulas take days to weeks to form as the tissue actually undergoes necrosis. And because the urine is constantly leaking out, the bladder doesn't distend. Bladder atony, on the other hand, presents immediately postpartum. We're talking an inability to void within 6 hours of delivery, paired with an acutely distended, palpable, and very painful bladder.
Let's quickly trace the pathophysiology. It kicks off with risk factors like primiparity, operative vaginal delivery, C-sections, perineal injury, and most notably, regional epidural anesthesia. These factors severely blunt the bladder sensation and stretch receptors. The direct result? Bladder atony. The bladder fills up, but it completely lacks the tone to contract. This leads to incomplete bladder emptying. As the bladder gets massively distended, the patient will experience small volume voids or continuous dribbling of urine purely due to overflow incontinence.
When a patient presents with this immediate inability to void and dribbling, you confirm the diagnosis by checking the catheterized residual urine volume. Management is incredibly specific. Step 1, recognize that this is a self-limited condition.
Most cases resolve spontaneously within a week as the pudendal nerve and pelvic floor muscles heal. Step 2 is your definitive management. Utilize clean intermittent catheterization to drain the bladder and prevent further stretch injury while the atony resolves.